We're pleased that you're here for the kickoff, the virtual kickoff for Cohort 2 of CARE Act implementation. So we're excited today to see so many of you on the line and to hear from this group to help orient Cohort 2 counties. So now that we're 2 minutes in, I just wanted to start off with some housekeeping items. So this call is going to be recorded. We will be sharing the recording and the deck will be shared after this meeting. So you don't have to memorize everything that you see. We'll be sharing this information. Please keep your phones on mute. There are a lot of people on the call. At the same time, we do want to hear from you. So we have saved a portion at the end of this call for Q&A, but keep your questions going in the chat. As you have questions, people will attempt to answer them via chat, but we'll save the last section for questions. And then we can always follow up. There's a post-meeting evaluation. So if you have additional questions that come to mind afterwards, please submit them there. There really is no wrong door. And then a note, if there are any security issues, we will just shut the meeting down immediately and we'll send you a separate email with information about how to join another call. So we appreciate everyone joining. Just on the screen, some navigational for Zoom. You've likely, seen these before, but we have the mute button. So just make sure you're muted. You can come off of video if you want to, but you don't need to either. There's the Q&A button and chat. Like I mentioned, please feel free to add questions throughout in chat. We'll answer them as questions come up, but we'll save the last portion of this meeting for Q&A, so you can feel free to save those questions for the end as well. So now I just wanted to have a high-level overview of the agenda for today's discussion, and then I'll kick it off and kick it over to the presenters. So we'll start off with that introduction and welcome from Cal HHS, and then we'll be joined by the Judicial Council of California to talk about their role and the role Judicial Council's role. Then we'll hear from the State Bar of California for a State Bar funding update, and then hearing from DHCS to introduce the training and technical assistance and data collection and reporting work streams, and then hear from Health Management Associates on training and technical assistance, and then on data collection. Like I mentioned, the last portion of the meeting will focus on next steps and Q&A. And after we close the meeting, you'll get an evaluation report, and we hope that you can fill it out and provide more information about what support you need. So with that introduction, I'd like to turn the time over to Stephanie Welch with Cal HHS. Stephanie?
Good morning, everyone. My name is Stephanie Welch. I'm the Deputy Secretary of Behavioral Health for the Health and Human Services Agency. And in that role, I have been intimately involved in CARE and the CARE Act implementation for Cohort 1 counties. I first want to start by thanking our Cohort 1 counties and really lift up how much they can be a tremendous, and I think will be a tremendous resource for all of you. And also our commitment to learning from Cohort 1 counties and capturing that information and making sure that through our partnership, both with the Judicial Council, as well as with the Department of Healthcare Services, that those lessons learned and tips and pitfalls, frankly, are things that we are capturing and incorporating on a regular basis into the technical assistance that you will receive. So really happy to be here today, and we'll go ahead and get started with the next slide. The next slide. So for those of you who have seen me present on this before, I'm always really, it's really important to me to really lift up some key elements of the CARE Act. First of all, I really would like to encourage all of you as you embark on your implementation planning to really focus on the CARE Act. To be frank and to be something that everybody on this call really already knows. While this is a new civil court process, I think most people think of court as a criminal process. And so I think it's really important and useful for all of our stakeholders, including people who will be working in this space, as well as being touched by the program, to really focus on the CARE Act process rather than the court process. So with that being said, to be really specific, this is a small target population of individuals who will receive this new tool, or be really the target population of this new tool that you have in your toolbox to serve people with very severe behavioral health issues. And specifically, these are individuals who are living with untreated schizophrenia spectrum or other psychotic disorders. We know that that is a very small portion of the population, less than 1%, and of that, less than 1%, really a smaller majority of that even really experiences significant challenges due to untreated schizophrenia. So again, with that being said, want to be really intentional in saying that this was really designed, kind of like the intervention, so to speak, that goes with this population was designed because this is a population that is significantly impaired, and quite frankly, and unfortunately, often are experiencing multiple psychiatric hospitalizations, incarcerations, and is at risk or has been conserved in the past. These are, in many cases, for those of you on the phone, people, the Zoom, people who you may know in your community or may not know, and that you have worked very diligently to try to reach and engage, and maybe have not had success in that. So also want to lift up that this is a population that often is experiencing homelessness, or is at least housing insecure or unstable. That being said, there are also individuals who may be in some sort of a living situation that can be supported through wraparound services in the CARE Act process. And I think it's really important also, as we were thinking about and designing this program, is that we really believe with very intensive services that this population can be so stabilized that they do not need to be in restrictive settings, that there is not a need for long-term conservatorship, and that with the right care and support and access to housing, that they can live in the least restrictive environment possible in the community. So with that said, we'll go ahead and go on to the next slide. So what is the role of our Health and Human Services Agency in this process? We are leading the coordination efforts between the Judicial Council and the Department of Healthcare Services, and really then liaisoning back to the administration in other ways, the governor's office, being responsive to questions from the legislature, the media, other stakeholders, etc. I'd have to say that, and I'm sure this is going to be a core theme that comes across in all the presentations that you're going to hear today, that partnership is key. I know you're going to hear from the Judicial Council and DHCS staff shortly, and I spend a significant amount of time with them weekly, and that has been instrumental in us being able to be successful so far with implementing this effort. So strongly encourage those kinds of partnerships at the local level. We're also responsive to partners at the city and county level, individuals who are reaching out to us and wanting to ask us questions about what care is and what care isn't. We also try to inform our various different stakeholders, especially some of our county implementation partners through CSAC and their affiliates. We also want to support DHCS and kind of try to weave and stitch some things together. As you are all very well aware of, there's an enormous amount of stuff happening in the behavioral health space. And it's really part of our role to make sure that we're coordinating, and that we're not just doing and implementing the CARE Act in a vacuum, but that it's really attached to other major initiatives that are happening in this space, including in particular for CARE, behavioral health bridge housing, but also soon to be other things like DH Connect. One of the really significant things we do, and I think we're going to talk about it more on the next slide, is the CARE Act work group. So I will go ahead and we'll move on to the next slide, and then I can touch on that in a bit. So this is a slide we like to share often, and it really is I think of it as air traffic control for all of you. I would print this out and maybe put it in a binder, or so that you know that when you have a question, these are kind of some of the areas of which you could go to. So for example, at agency, I'm always interested in taking people's questions. When you ask questions, we learn. And we made a commitment to a really robust kind of early implementation process. And so that when you ask questions, we learn, and it helps us do our job better. But in general, we really are the kind of coordination and engagement with our cross-system partners. We meet with our veterans folks. Obviously, there's a significant SUD component to this, and there's a lot of involvement with our public safety partners. And when I say public safety partners, that's inclusive of all of our court partners. And so lots of work in that space. And we are also creating a learning community through a subcontract that we have with a team that is supporting us, and really just interesting things happening in there, just making sure that outreach engagement workers are connecting with other outreach engagement workers in Cohort 1 to share tips of the trade, et cetera. And we continue to look for interesting things that we can do in our capacity to convene people to share lessons learned in particular. You're going to hear both from the Judicial Council and DHCS today. They do extensive training and technical assistance to their constituencies. Obviously, the Judicial Council is working with judges, counsel, and the courts. Our DHCS partners are really focusing on our county family, in particular behavioral health. But I'm sure what you will see in the outline today is that it really behooves county behavioral health to have a tight partnership with their social services and housing partners. And of course, if your public guardian or your conservator is not part of your behavioral health department, I think they also play a really important role, as care is a really, we're hoping, and it really is kind of turning out to be, an off-ramp to conservatorship or diversion from conservatorship. I'm sure DHCS is going to go into detail about all the work that our HMA partners are doing to support the success of this implementation. And then for all of you, hopefully you're thinking about how to utilize your startup funding to really have successful planning and implementation, that you're building capacity to even participate in such robust TA that we'd like to provide. And of course, there's a significant opportunities to create a learning community. And as you will hear today, some pretty robust data collection components. And that's really important to us, because we made a commitment with CARE that we wanted to know that if this new program, because it is a new program, if this new program is really doing what we wanted it to do, and again, going back to those early slides, we wanted to make sure that it's reaching the right people, and that hopefully is reaching people to avoid what we feel are pretty traumatic circumstances and events, such as multiple hospitalization, incarceration, and potentially long lengths of stay living unhoused and without any access to care. Okay, next slide. So this is one of the main things that we do. I'm super appreciative that we have some pretty good county participation. Tuolumne, Fresno, Orange. Gosh, I'm going to forget somebody. Of course, those are our county partners of Sacramento who participate. But we also have what I would say are excellent. It's an excellent representation of what could be a planning body at the local level. We have everybody from peers and families to our legal aid partners, disability rights, our homeless service experts, hospitals, really everybody who touches this population and is interested in the shared goal of making sure that we have the ability to serve people better and get them better outcomes. The purpose of the CARE Act Working Group is really to promote coordination, really to lift up successful implementation of the CARE Act is where we're going, and would really encourage people, if you're interested in tuning in, we've got the dates there of our upcoming quarterly meetings for the year. Next slide. So if you are not engaged already and you are very interested in being engaged, we do have 3 ad hoc sub-working groups. People do really technical work here that's super helpful, everything from sharing evidence-based practices to thinking about how we can have a strong and robust independent evaluation that really tries to get at some of the questions that we're trying to get at with care, such as, does this really impact and improve people's lives? And so you see those there. You can certainly sign up for any of those through the Care app website. And I think we have a bunch of websites towards the end of the slide deck. Next slide. I want to make sure I definitely touch on this. I know others will as well. We really feel that we're in a good place right now. And I spent all that time talking about the importance of the narrow targeted population because we did not conceive this as a huge program. We do conceive this as a program that would really touch somewhere between 7,000 and 12,000 Californians, and that we would take a few years to get up to that point because we are starting a new program. So the fact that we have over 200 petitions, I think we've got a little over 220 petitions, that's a good pace for us at this point. It's a responsible pace, and it shows that petitions are thoughtfully being submitted. And the fact that we have not had significant numbers of petitions dismissed or basically reviewed by the judge and seen as not meeting the criteria for care means that people are working really hard to submit high quality petitions. Again, I think for us, this really provides opportunity, and I'm sure the Cohort 1 counties could speak for themselves, to really build this capacity that they want to build to have strong and robust comprehensive care plans for those who are coming through the system. Next slide. Oh, excuse me. And this is where I'm going to wrap up. And I don't think this will be any surprise to those of you in the audience. I mentioned it before. Number one thing you can do starting today, I'm sure many of you have been already doing this, frankly, and have done it in other spaces. Maybe you've gotten together with these partners to try to address the IST crisis in your community, or you're starting to do some planning around CalAIM justice impact work. Or you sat down with your conservatorship or public guardian office and said, hey, how can we try to improve the placements for people who are conserved, or try to reduce our number of people who have to be conserved. Partnership. And I've been incredibly impressed by all 7 counties in their partnership, and I'm sure they have wonderful lessons that they can share with you. Communication. Great things to beg, borrow, and steal from your fellow counties in terms of how they communicated with family members, with their local elected officials, with their press, with peers and other advocates in the community. Really is important to be consistent with the information that's being shared and to tell your story about who you're going to serve, that it is consistent with what the statute is directing you to do. I know that hiring is an incredible challenge all over the state, has been pre-pandemic, and we continue to struggle with it. But I've been very impressed by the ability of our Cohort 1 counties to staff up and prepare to serve this population. And I hope all of you have your behavioral health bridge housing funding. You should. There's a new round of funding that is out there that you can apply for. I would imagine DHCS might touch on this, but it's really exciting that there's going to be some new creative, hopefully flexible and innovative ways you can use those dollars to access housing as soon as possible for this population. So with that being said, I think I'm done with my slides. I think there's maybe one more. Thank you very much for letting me join you today. And I'm going to pass it off to my colleague, Charlene Deppner. She's the director for the Center for Families and the Courts. I work with Charlene on a regular basis, and the Judicial Council has been an incredible partner. So thank you, and I'll pass it over to Charlene.
Thank you, Stephanie. I really want to echo everything you said about the value of interagency coordination and communication. It is the key to a successful implementation. Hi, I'm Charlene Deppner. Thank you so much, Stephanie. And okay, I'm getting messages coming across my screen. Sorry. I'm Charlene Deppner. I'm the director of the Center for Families, Children in the Courts. And I want to thank Stephanie and all our other partners for the work that they've done in building interagency coordination and communication across all levels, state and local. And I think that is the key to success for your planning. And we know that no two courts are alike, and the responsibility of the Judicial Council is to make sure that you get the tools you need, the consultation you need, the resources you need to build a CARE Act plan that fits your local needs and the way your courts operate. And we are here to help you do that. There's a list on the screen of the kinds of things that we're responsible to do, and that is to assist you in this implementation. We have created rules and forms and legal information for you, and a host of trainings that help you get started. If you are on JRN Network, for the Judicial Council, you can see a sort of chronological list of trainings that will help you at every phase of development. I totally agree with Stephanie's urging to start looking into staffing and to start building relationships among the agencies that you'll be working with. It'll make things much easier. Our responsibilities also include judicial education and data collection. And we want to kind of spotlight a few other things that we're going to be looking at. So my colleagues will be talking about those in general. So I'm going to turn this over to Teresa Chung.
Thanks, Charlene. Good morning, everyone. My colleagues and I are excited to be here with you to kick off implementation of the CARE Act with the various CARE team members, as well as the Cohort II members. So as Charlene has mentioned previously, part of the Judicial Council's role is to provide training and technical assistance to judicial officers and the courts. And as Stephanie mentioned, there has been a lot of collaboration across agencies since implementation has started. So throughout the last year, the Judicial Council has worked collaboratively with other organizations, assisting in the development in a wide array of trainings and resources. Some of these trainings are noted here, which include trainings on an overview of the CARE Act and CARE Act process, housing in the CARE Act, care agreements, plans, and orders, as well as a primer on confidentiality, and a training on effective communication and reasonable modifications for court users with psychiatric disability. Meanwhile, resources that have been created include a CARE Act implementation toolkit for Cohort II courts, consisting of bench scripts, checklists, flowcharts, and other resources. And as Charlene had mentioned, those are on our JRN website for the courts to access. Oh, next slide. So in addition to providing support to the courts, the Judicial Council has developed resources specifically for the public. These resources can be found on the California Courts Civil Mental Health page, and there you can find CARE Act eligibility criteria video, CARE Act 101 webinar, as well as a toolkit, which includes fact sheets, a glossary of terminology, more eligibility sheets, as well as a list of the CARE Act locations, court locations, which includes information on where petitions are filed and when and where hearings are held. Next slide. And lastly, this is a list where you can find the trainings and resources previously mentioned. Listed is a link to the California Courts Adult Civil Mental Health page, as well as a link to the CARE Act page on the self-help website that has an abundance of resources as well. And lastly, we have our CARE Act email address noted here, where you can email if you have any additional questions. And now I'm going to pass this on to my colleague, Melanie Snyder. She's a supervising attorney at the Judicial Council, and she works closely with the self-help centers.
Thanks, Teresa. So as Teresa said, my name is Melanie Snyder, and I am a supervising attorney with the Center for Families, Children, and the Courts. I wear many hats, but one of them is to act as liaison with the with the State Bar's Office of Access and Inclusion, and you'll hear more about that from Chris McConkey, who will talk next. And that program oversees the public defenders and the legal aid programs, so the counsel for respondent, basically. The other piece of what I do is work with self-help centers in the California courts. And I don't know if you're all aware, since you're not court people, that every county has a court-based self-help center. And so we have found in Cohort 1 Plus, I want to leave Kathleen out of there, that most of the petitioners so far have come through the self-help centers. And so you should know that self-help centers exist. And then the other thing I want you to know is that we are going to host some internal convenings in April. And at about that point, I think that your local self-help center folks will start reaching out to you, because what you've heard is the truth, and we really need to build those relationships. They've just been so important to getting just quality petitions and people the help they need. And it's just vital that we work together. So I look forward to reaching out to you and learning more about your local programs this spring. Thanks so much. And I also just want to say, gosh, the relationships are helping in other areas of what we work on. So we really, really do value your support and the ability to work with you. So thanks so much. The Carrot Self-Help Guide is listed on the page here, so please feel free to go look for it. All right, now I want to reach out to Chris McConkey from the State Bar's Office of Access and Inclusion and turn the program over to him.
Good morning, everyone. Thank you, Melanie. My name is Chris McConkey. I'm a program supervisor in the Office of Access and Inclusion at the State Bar. We can go to the next slide. I'll take just a couple minutes to describe yet another prong that Melanie, Charlene started to describe, which is the role of Respondents Council and how those entities that provide that important part of the CARE Act are funded and what kind of reporting they do. So we'll go to one more slide. The State Bar of California, and in particular the Office of Access and Inclusion, administers the funding and reporting for the attorneys that represent respondents in CARE court, in the CARE process. And they do that through the Legal Services Trust Fund Commission. So the reason that the State Bar staffs the Legal Services Trust Fund Commission is it is part of the State Bar's mission to promote access to civil justice in our state's legal system, which is inclusive of this work in the CARE process. Just so you know, the commission administers a lot of other state and federal funding for legal aid as well. It actually administered over $170 million in 23, and it's going to be even more next year. Most of the funds go to nonprofits that go through a rigorous vetting process to qualify under a statute to receive these funds. And some of those nonprofits can serve as counsel to Californians going through the CARE process, counsel to respondents. Those nonprofits under the Business and Professions Code are called Qualified Legal Services Projects. And there's another category of nonprofits called support centers that can also receive funding under the CARE Act and each year's Budget Act. So these are important organizations that play a role in the CARE process. The Qualified Legal Services Projects, or QLSPs, might be representing the respondents in your county. Support centers might be providing legal training and technical assistance to Respondents Council. And then, as you may already know, the CARE Act says that if a Qualified Legal Services Project, or a QLSP, is unavailable to represent someone who's going through CARE court, then the CARE Act requires that the court appoint a public defender office to represent them instead. So go to the next slide. The Budget Act of 2023, which was this last Budget Act, specified that the commission would also administer funding and reporting to the public defender offices in each county to the extent that they were providing the representation for respondents, which for this ongoing state fiscal year 23-24, so as you may know, that's Cohort 1 and LA County, was actually the public defender office in every single county that provided those services, except for one county which had 2 nonprofit qualified legal services projects and the county public defender office that are all available and ready to provide representation. That county is San Francisco. The other counties, it was the public defender office. For 23-24, that's a reference to the state fiscal year, the minimum amount for representation for respondents was $20,400,000. Each county kind of got its fair share according to a funding formula. And then nonprofit support centers and other entities could receive up to a little over $1 million total combined to provide legal training and technical assistance to Respondents Council. So this last year, there were 2 QLSPs. Those are nonprofits that got funding to represent respondents in San Francisco. And there was one entity that's called in the Budget Act, an other entity that received a grant to provide legal training and technical assistance. The rest went to public defender offices. I think I have 2 more slides. Go to the next one. So the funding for offices representing respondents going through the care process, we anticipate looking at the distribution and the parameters, the need to run a funding formula to see how much each county is going to get. We anticipate that it will be similar this next state fiscal year as it was to this year. There are some key structural differences, of course, like Cohort 1 in LA County will have already launched their care courts come July 1, the start of the fiscal year, versus 50 other counties will be launching by December. So, of course, there's going to need to be timing differences in payments and perhaps also when nonprofits might be applying for receiving grants. But otherwise, we think there will also be a lot of similarities. The Budget Act of 2024 would be the vehicle for this funding, and that, as you may already know, is likely to pass in late June. It often passes in mid to late June. So the commission, the state bar, and others will likely have to wait until the Budget Act passes to finalize any of the funding for those representing respondents in care court, public defender offices, qualified legal service projects, and those providing technical assistance. That being said, the commission, the state bar, the Office of Access Inclusion do anticipate trying to release a lot of information, possibly including a request for proposals for nonprofits this spring, and doing everything that kind of can before the Budget Act passes to get the process going. I have one more slide. And since you heard a little bit about the reporting for other entities that are participating in the implementation of the CARE Act, I just wanted to note that public defender offices and those and qualified legal service projects and those providing legal training technical assistance to them that get funding through the State Bar of California also are going to be reporting. Their line of reporting is a little different. They'll report to the State Bar of California, to the Legal Services Trust Fund Commission, and that data is shared with the Judicial Council of California. And then I think eventually it either has to or will become part of reports that get filed, and we'll go through Cal HHS and or DHCS. So there's reporting from those entities as well. It kind of follows a different path, but it all ends up in the same place. The reporting also, the data looks a little different. It has a focus on legal outcomes, which is something that the legislature requires the commission to collect from its other funding recipients. The State Bar of California is regularly meeting with the organizations it funds, and that has included offering webinars, convening them virtually, and we've most recently scheduled an in-person convening for public defender offices, qualified legal services projects, and other entities and support centers for both Cohort 1 and 2. Again, this is an emphasis on those that will be representing respondents, and that in-person convening is going to be on February 13th. I believe that's my last slide, so I'm very happy to turn it over to Ivan.
Thank you, Chris. Yes, I'm Ivan Bardwaj. I'm Chief of the Medi-Cal Behavioral Health Policy Division within the California Department of Healthcare Services. And I'm very excited to be here. I met last week with the North Coast counties with Stephanie and Charlie as part of our Cohort two meeting. And I noted it was kind of the first foray following a culmination of a year plus of work. And this is even kind of more exciting because it includes the kind of full scope of Cohort II county partners. So, just quickly in terms of who I am, my team and I oversee the policy components of the specialty behavioral health plans, including the Drug Medi-Cal organized delivery system and county mental health plans, where specialty mental health services are delivered, and then specifically oversee a lot of the CalAIM behavioral health projects like No Wrong Door, Access Criteria, and mobile crisis services, but also kind of other intersecting initiatives like 988 and of course the CARE Act, which I'm delighted to be speaking about today. I think we can go to the next slide. So this is an overview of the various components that DHCS is responsible for. We are under the purview of CalHHS, our parent agency, which is they're doing a lot of the coordinating for us, as Stephanie had noted. But we do have a specific scope of activities, and that includes training and technical assistance to be able to support CARE Act implementation through kind of webinars, digital materials, one-on-one coaching, which I'll get more into in a second, and other resources. And our training and technical assistance is supported through our contracted vendor, Health Management Associates. That's really and they're really focused on ensuring that counties are fully geared up and prepared to implement the CARE Act. And they've developed kind of numerous trainings on a host of topics, including kind of like the basics on like the CARE Act process, the role of peers in care, and really kind of a lot of detailed components like the role of the family in the CARE Act process, the role of volunteer supporters in care, and then of course our data collection and reporting. There's a really great full suite of webinars and resources available on their website, which is care-act.org, but we'll share more about HMA in just a few moments. But also wanted to cover kind of what else DHCS is responsible for, which includes a lot of different reports, and we're responsible for a preliminary report that will be published on December 1st, 2024 with trial court data that will nicely coincide with the launch of Cohort II, and then an annual report that will be published on July 1st, 2025 of every year that includes, kind of a host of outcomes data and performance measures. And then lastly, in terms of reporting, we have an independent evaluation that we really have an annual report data kind of fed into it and serve as a more robust report to be able to tell the story of care. And for the independent evaluation, there's really two reports. There's going to be an interim report that's to be published on December 31st, 2026, and then a final report following that in December 31st, 2028. We're also responsible for the fiscal elements. That includes startup funding, claiming guidance, and accountability and sanctions guidance. And the next slide notes kind of the behavioral health information notice for startup funding, but our claiming and accountability guidance is kind of imminently forthcoming for our stakeholder feedback. And then lastly, we're responsible for publishing guidance on the parameters around delayed implementation, which is already live. And I think it's on the next slide if we want to go to that. Yep, so we have our 3 behavioral health information notices here, and the first of these is the startup funding. That's been 22-059, and as I noted, we have guidelines for delayed implementation, and then of course data collection or reporting, which has this kind of CARE Act data dictionary, which is really, really detailed, and is hopefully a really helpful tool for counties in terms of being able to collect the necessary data for care. And then we do have other bins in development. Like I noted, we have some fiscal ones underway, but we'll be continuing to publish policy guidance on our webpage and inform all of you of the latest guidance as it comes out. We can go to the next slide. So here's a high-level overview of our CARE Act implementation timeline. excited that we were able to launch with the first counties by the end of last year, with 7 in October 2023, and they're listed here. And then we've got Los Angeles that launched in December 1st, 2023. And then, of course, we have all our Cohort 2 counties required to launch by December 1st, 2024. You can go to the next slide. So here's some upcoming milestones that are currently underway and in development, and DHCS is kind of developing and further refining the key performance indicators based on outcomes measures listed in the CARE Act. And that includes criminal justice involvement, SUD rates, detentions, and other LPS involvement for participants, services and supports, treatments that are both continued and terminated, and then rates for adherence to medication. We've also got our independent evaluator, the RAND Corporation, officially under contract, and we'll be closely partnering with them on the development of the evaluation components. And like I said, we're going to be issuing guidance regarding sanctions, reimbursement rates, and claims information over the next few weeks. And then we've got Cohort 1 first quarter data that's due March 1st. So we're all very excited to see that. And lastly, as I noted, we'll be publishing an early implementation report with trial court data by December 1st, 2024. I think we can go to my last slide here. So I introduced HMA a little bit, so I won't spend too much time here, but I just want to note that they've been really instrumental in the development and launch of the CARE Act. They've been working very, very closely with the Cohort 1 counties. And I noted this to the Cohort 2 North Coast counties last week, but they are going to become your BFFs for all CARE Act implementation, data collection, and reporting, and then the training and technical assistance that they'll be providing throughout as you kind of work through your planning and implementation of CARE through December 1st, 2024. And I just want to note one really kind of important, innovative, and really effective component of their training and technical assistance, and that's their one-on-one coaching model. I think many of you may be feeling anxiety about implementing CARE, which is understandable, but HMA's training and technical assistance approach includes kind of true one-on-one coaching, where they work directly with counties on the specifics and unique challenges that they've, that counties will be kind of experiencing. And we know that there are vast differences between counties, even in those in the same region. And HMA is here to kind of understand what the idiosyncrasies are for each county and work collaboratively with counties in overcoming any planning and implementation barriers for CARE. And so it's not just for the planning and implementation, it's also post-implementation. We do have them under contract for a few years, so they will be critical partners, not just through this year, but also following that as well. So with that, I think I can hand it off to our colleagues at HMA, and I will give it to the HMA project manager, Laura Collins.
Thank you, Ivan. Hi, everyone. Good to be here. Good to see you all. Yes, I'm Laura Collins. I'm here with my colleague, Amanda Turnan, to introduce HMA and talk a little bit about our training and technical assistance activities to really support your successful implementation and CARE. So let's go to the next slide. So after I introduce you to our team leadership and partners, we'll briefly share the CARE Act Resource Center website. These are sort of the topics we're covering quickly today. We'll share Cohort 2's current status with regards to CARE activities. We'll touch on the implementation resource guide that's in progress right now. We'll touch on our QI activities to date. And we'll finish with a glimpse of what is ahead for calendar year 2024 and 2025 with regards to our training and TA activities. And then we'll hear from our data lead, Dr. Serene Olin, to discuss a little bit more about that data collection and reporting and CARE that Ivan was referencing. So let's go to the next slide. So briefly, for those of you that are not familiar with HMA or Health Management Associates, we are a leading independent national research and consulting firm in the field of healthcare that, as Ivan mentioned, we've contracted and partnered with DHCS to provide training and technical assistance support to really support you all in your implementation efforts. So starting with our leadership team, here's a snapshot of our team, starting with yours truly as the project director, Laura Collins. And then, as I mentioned, Amanda Turnen is our project manager. Dr. Serene Olin is our excellent data team lead. Patricia Doxey, who you heard at the beginning today, leads and organizes all of our training activities. And finally, Dr. Deborah Rose, who supports our team as assistant director for this project, primarily providing key curriculum support. And let's go to the next slide. So here are our work stream leads. So CARE covers a lot of ground, really requiring expertise in a broad range of areas, including behavioral health, housing and community supports, data, and of course, legal, specifically California mental health law. We also have our county liaison coordinator, and importantly, our comms or communications support team, Merit and Grace. And let's go to the next slide. So in addition to the subject matter expertise that HMA brings to this TTA work, training and technical assistance work, we have a number of partners who bring their expertise from the perspectives of the peer, that would be Painted Brain, and the family. Specifically, we've partnered with Linda Mims and Shay Franco-Clausen as these subject matter experts with that bringing that voice. So that said, HMA with DHCS and Cal HHS, we also partner with others, including Judicial Council, of course, who you've heard from today, and leadership from Department of State Hospitals, or DSH. We also solicit feedback from county team members, really as local subject matter experts, and from other key stakeholders, including advocacy organizations such as NAMI and Peer Voices, just for a couple of examples. Let's go to the next slide. So I'd like to talk a little bit about the county liaison role. And that's, Ivan was speaking of it in terms of a coaching role. It really is both. But we broadened from coach to liaison because there is such a broad scope of work and care. And we really wanted to identify folks that could be responsive in that liaison role to triage requests to the right coach, the right subject matter expert to support, again, your county's implementation needs. So what is a liaison? Liaisons are really that single point of contact for the teams, for the county teams. I think we heard it earlier from Stephanie. They're another version of air traffic control in terms of really managing requests, triaging questions, and technical assistance requests, meeting requests. They really make sure your team is getting any updates. They can connect you, as I mentioned, to the appropriate subject matter expert or that appropriate resource to, again, support your implementation readiness. And the 8 counties who've already gone live with CARE have already been supported by liaisons this last year. So we've now expanded liaison assignments to all 58 counties, which are noted here on the slide. So you'll be hearing from your liaison. They'll reach out, that person will reach out to your county and schedule that initial call and set up those regular check-ins. We're also looking at other liaison-supported meetings by affinity group, such as a housing or rural affinity group, or by region. There's more to come on that topic, but we're really trying to be thoughtful about organizing other meetings other than that, one-to-one meeting with your liaison, really to, again, to bring affinity groups together, bring counties together to problem solve as well and support that problem solving effort. And if you do have a single point of contact or a list of key county care leads for your county, please send that to us, that information to us at info@careact.org. If someone could paste that in, or I can paste it in a minute too. It's always good for us to know who to reach out to if we don't already have that contact information. And from there, I'm going to hand the floor to Amanda to introduce the CARE Act Resource Center.
Good morning. Good morning. Happy to have everyone on the call today. The careact.org we call the Resource Center, and this was developed in partnership with our communications vendor, Merit and Grace. The Resource Center launched last year and has grown considerably. In this resource center, all of our training and resource material are posted. So even if we've conducted a live training, the deck and the recordings will be posted, usually within 10 days on the website. We also have a series of many asynchronous trainings that are also posted, both the slides as well as the recordings. We have FAQs, and we also have many different ways to get connected. We do encourage you, if you have not already, to join our listserv. We also have specific requests if you're looking for TTA support. We have a separate request if you're looking for specific data collection and reporting support. And we also have a general stakeholder feedback form that could be submitted anonymously, just if you wanted to share any thoughts and feedback on any of the trainings and resources. Next slide. In 2023, like we mentioned, we did launch the website, and it was fast and furious as soon as we did. Last year, HMA, in conjunction with many different stakeholders, presented 18 live events addressing topics from the care process, roles, services and support, supported decision-making, data collection and reporting. We also had 11 additional trainings that we provided asynchronously, including a trauma-informed care series for both BH as well as volunteer supporters. We have a lot of additional resources uploaded. Those can be things like a fact sheet, an issue brief, one-pagers, and then we continuously post FAQs, and those are able to be searched by categories. By joining the listserv, you will also receive our eBlast newsletters that will come on the CARE Act Resource Center. Any past emails are always listed, so if you miss something, you can always go back to that CARE Act Resource Center to see what was included in that past newsletter. Next slide, please. The trainings and resources. So we recently have, as of yesterday, launched some edits to our CARE Act Resource Center, which we're very excited about. We changed the layout of the pages to make it easier for users to scroll through the available materials. We also have a new to the CARE Act recommendation. So these are more of foundational materials. So if you have staff members who just don't know anything about the care process yet, but they want to start attending more detailed trainings, we always suggest to go to these foundational trainings and resources just to get an overview of the care process. We also do all the recordings and trainings for many of the care process topics. And on the next slide, we'll show you how to locate some of these trainings and resources. So part of our upgrade to the CARE Act Resource Center, and you can go to the next slide, includes new searching functionality. So we've added an IMA audience. So if somebody is a community member or a family member or BH agency, by selecting that different audience type, there'll be some recommended trainings and resources available. You can also search by keyword or phrase, as well as topic and material type. So we found these new changes to the website that we launched yesterday a valuable asset in being able to identify resources that will benefit you. And on the next slide, also on our resource center, we have a drop down for the county websites. So most of Cohort 1 counties have established county-specific CARE Act websites for both their county behavioral health as well as their courts. We have the directory on the CARE Act Resource Center, and that directory also includes the search for the county-specific self-help centers that Melanie mentioned earlier, as well as links to the local NAMI affiliates. Next slide, please. As part of your registration, we asked you a few questions, and so we wanted to report out what we heard from you. In regards to whether or not your county had initiated or completed any CARE Act implementation planning activities to date, we had 38% yes, 17% no, and 45% unsure. For counties that have multiple team members attending, there were many instances where some members said yes, and some members said no, and some said unsure. Most of the yes respondents were in the administrative or management role within their county. Out of those that said yes, the reported activities mainly dealt with some planning efforts, as well as starting some collaboration with courts and other stakeholders in their community. Many had started workflow development between courts and BH, education and training for both internal and external staff and stakeholders had started. Communication efforts were beginning, and some reports of some housing efforts, staffing, and cost budget analysis and IT and data prep. For reported challenges, 53% had concerns with some staffing around staffing and resources. So some of it is just unknown county impact, burden on existing resources. The understanding of the CARE Act and the workflows and how the collaboration will work with the courts was another reported challenge. And then with funding and budget, again, just some unknowns about the impact, number of petitions, and then following through with some housing concerns, both from infrastructure and availability, as well as additional structures needed across the courts and the DBH agencies and self-help centers, and the following with some rural specific concerns, as well as IT and data questions. And I'm going to pass it back to Laura. And
Laura, you're on mute.
Thank you. Thanks, Amanda. Yes, thank you for that. We wanted to speak briefly about the implementation resource guide that is coming soon and will be made available as an optional resource to Cohort 2 counties. So this guide includes a list of recommendations, resources, and timing suggestions for county behavioral health, really, again, to support your implementation activities related to CARE Act. You'll see on the right the general categories that are covered in this guide, including coordination and communication activities, the care process and workflow guidance, including specific topics on engagement strategies, data collection and reporting, legal topics, including privacy and confidentiality in care, staffing for care, which we're hearing is a priority, including hiring, training, and retention strategies, the volunteer supporter role that counties are still sort of in planning efforts around even Cohort 1 in LA. The family and peer potential roles, housing strategies, general go-live readiness tips, timing recommendations for these implementation activities, and resources, including relevant trainings and other links. So in addition to our training and TA activities with Cohort 1 informing this guide, other stakeholders, including Cohort 1 and Los Angeles counties, very much contributed to the guidance in this implementation resource guide as they shared their insights and their lessons learned from their preparation and implementation activities. So more to come on the implementation resource guide. We saw that there was some interest today on that, so more to come there. Let's go to the next slide. So our team has used a variety of methods to get input and feedback on our TTA, or training and technical assistance activities. Our primary methods to get this feedback have been via our TTA survey, post-training evaluations, county outreach, and input from the working groups and other county convenings. We also provided a training and technical assistance survey to CARE Act stakeholders and gathered input on both the topics and the formats that have been really the most helpful, and also identified gaps in this survey. So some of our key survey takeaways included additional training and or technical assistance on the care process, care forms, technical assistance or training on reimbursement, and a big one was supporting coordination and cross training with the courts. Really, there was an interest in facilitated conversations between counties, especially between Cohort 1 and Cohort 2 counties. So on the slide, you'll see some of the improvements in planning in response to all the feedback. And I'll just highlight a few of these in the spirit of time. So to tailor trainings and provide more comprehensive topics based on specific requests from counties. Continue to provide county-specific resources and technical assistance with help from the liaisons and a proactive approach that at that, essentially. So also continuing to update the CARE Act Resource Center as Amanda demonstrated. We continue to improve on the Resource Center for ease of use in locating trainings and resources and continue to develop that supporter toolkit and implementation guidance. And very importantly, ongoing FAQ development as those themes come in and we capture those, respond to those, and share those on our resource site. Let's go to the next slide. So while last year's trainings included valuable foundational topics, many which were required by statute, this year's trainings bring a focus on better understanding how care is operating in practice. Again, we identified many additional TTA opportunities during those QI activities I just covered, and via the many engagements with stakeholders we've also just mentioned. So for the 2024 and 2025, or at least the first 6 months of 2025 calendar years, here are some of the topics that are under discussion. And I'll also quickly note that the training and technical assistance plan is really subject to change based on any emerging needs and priorities voiced by you, the county stakeholders, and other stakeholder feedback. But so far, here's a snapshot of new trainings and or technical assistance for calendar year 2024 that are under consideration. So we're definitely prioritizing outreach and engagement strategies based on feedback, assessment activities in care, treatment planning in care, first responders in the CARE Act, housing topic, focusing on system, process, and referral pathways, strategies for the justice impacted population in care, issues unique to rural counties, very important. And we also have a series of behavioral health topics, both for BH organizations and non-clinical professionals that include an Understanding Schizophrenia Spectrum series. We'll start with that. That's coming soon. And so our upcoming and or updated trainings include, of course, data collection and reporting that you'll hear about shortly. We have a considerations for petitioning in care training topic that's set for late February. And we also have some additional resources, including a training on family psychoeducation that'll be recorded and a resource guide that is in development. And of course, CARE Act updates will be included in this year and next year's topics. So some trainings are going to be conducted live and followed by an open forum discussion, and others are asynchronous or pre-recorded trainings that are uploaded to the CARE Act Resource Center. So in this year's and next year's trainings, we will be reaching out both to Cohort 1 and in some cases Cohort 2 for additional participation in the trainings and technical assistance activities to really provide that more local and focused support or expertise to county stakeholders. So from there, I'm going to pass the floor to our colleague Patricia, who will start a poll with all of you.
A similar question will be included in the post-meeting evaluation, but we thought it would be helpful now to get a sense from you what your preferred modalities are. So the different ways that make sense for you to receive training and technical assistance. So look over these questions. I'm going to launch a poll and just give your reaction to what makes sense for you, what you prefer, some of those synchronous or the live virtual trainings. Something like this where we have presenters, there's a time for Q&A, open forum discussions, that's more informal where it's primarily a conversation, pre-recorded trainings up on the website. We have a library. Amanda mentioned there are 18 events last year. Some of those county specific technical assistance sessions moderated by your liaison or one of our subject matter experts. We have office hours where you can drop in and ask questions or facilitated conversations with other counties, or virtual cross-sector sections with BH, courts, different groups, and then affinity groups. So this is like-minded or counties facing similar issues. That could be rural counties talking to other rural counties, urban counties talking to other urban counties, or similar issues that may be faced. So we see some answers coming in. We'll share those results in just a moment. But this is really helpful for us to know. Like I said, a similar question will be coming through in the evaluation, but this gives us some really helpful information on what you're looking for in this coming year. So we appreciate you taking the time to respond now. So I'm going to go ahead and move forward. Laura mentioned some next steps, some training and opportunities. We'll be sharing these as well in a moment. So I'll just turn the time over to Serene to talk about data collection and reporting. Serene?
Thanks so much, Patricia. Hi, good morning. My name is Serene Olin. As you all heard, in addition to the TTA for care implementation, a team of us here at HMA is also supporting DHCS with the development and management of the technical components of the data collection and submission process. So next slide, please. So today I'm going to provide a very high-level overview of the data collection and reporting process as shown on this slide. Our team had the privilege of working with Cohort 1 and LA County, who provided a lot of input to shape how we built out the data collection and reporting tools. So today, my goal really is to point you to available resources and trainings and to let you know that our data team here is available for technical assistance. So next slide, please. So this slide shows DHCS's responsibility related to reporting on the CARE Act legislation. And as Ivan mentioned previously, it includes two components, an annual report that you see on the left side of the slide, and an independent evaluation, which is on the right side of the slide. HMA is supporting DHCS in developing the annual report. RAND will conduct the independent evaluation. For the annual report, we will be collecting data to monitor the implementation of the CARE Act, and this will include outcomes data to assess the scope and the impact of the CARE Act. It will also include performance indicators with attention to key demographic information to support disparity reduction efforts. Data collection for the annual report will feed into the independent evaluation, and DHCS is coordinating both efforts really closely. So next slide, please. So I think as Ivan mentioned, one of the key activities related to developing a robust data collection and reporting mechanism involves creating a data dictionary. And this data dictionary is key for standardized reporting of data elements from both the Judicial Council as well as from the counties. And so this slide essentially shows the approach that the data work group took to developing the data dictionary. It was a very involved process. We started in February of 2023. The work group consisted of members from various DHCS departments, Cal Agency, Judicial Council, amongst other stakeholders. So the development, as I mentioned, began way back in February of 2023. We took time to review statute data requirements, research available data outside of the behavioral health agencies, and looked for opportunities to link to other data systems as well as data sources. The data elements were defined using existing state dictionaries for alignment, and with state definitions did not exist, we relied on industry standards or evidence-based typologies to define these data points. As you can see in the third column, we had a robust mechanism for gathering feedback. We gathered feedback from the CARE Act working group that Stephanie mentioned earlier. We had discussions with a variety of stakeholders, involved the counties in a variety of different ways by one-on-one calls, discussion webinars, and formal review of the draft data dictionary. We also involved key organizations representing both court, county, and other interests to ensure robust input into the data dictionary. And then finally, I think it's Ivan mentioned earlier, we followed a process for integrating the input, and we finalized the data dictionary, including a period for public comment in September, and then ran the data dictionary through a final approval process through DHCS. So next slide, please. So again, as Ivan mentioned earlier, the data dictionary was released in October by a behavioral health information notice. And now that the implementation of the CARE Act has commenced for Cohort 1 as well as LA County, we have set up a data governance work group to provide oversight of the CARE Act data collection and reporting activities, and to perform quality improvement to support the annual report as well as the independent evaluation. The work group members also participate in agency-led data collection and reporting ad hoc work groups. So multiple channels for input into how CARE Act is being implemented with using the insights that we're getting from data being submitted. So next slide, please. So I wanted to just briefly, next slide. Thank you. So I wanted to really briefly review the data reporting responsibilities for both judicial council as well as the county. So this slide here are the data points that are required per statute from judicial council. Judicial council is responsible for collecting 6 data points that you see here. They are related to petitions, hearings, and the development of care plans and agreements. And these data points will be reported at the aggregate level and stratified by county. So the 12 courts will not have a mechanism to submit data to DHCS. Instead, they will submit data to judicial council, who will submit aggregate data on their behalf to DHCS. So next slide, please. So on this slide, we show you the data reporting responsibilities for county behavioral health. So counties are required to report individual level data in a variety of domains that you see on this slide, ranging from basic client information all the way through hospitalizations and emergency department visits. These data points, you'll see 3.3 and all the numbers before them. These data points correspond to the data points that you will see in the data dictionary. And if someone could actually drop the link to the data dictionary in the chat, that would be great. So counties are essentially required to provide data at the individual level to the extent that data is available. So next slide, please. So this slide, and you wanted to just very briefly go over the 2 options for submitting data to DHCS. The first option is via SurveyMonkey, which was demoed during a live training that has been posted on the CARE Act Resource Center training page, and we'll provide the link in the chat. It's also on the slide. The second option is called the Move It file transfer application, and this is so the training for this was conducted just last week and will be posted to the Resource Center training page as well. So essentially, Move It is a file application mechanism by which county behavioral health can use a data file format that we will provide and use that to submit bulk data to DHCS. What's important to note is that while there are 2 options for data submission, for every reporting quarter, counties can only choose one way to submit the data. So for example, for Q1, if County A chooses to use the Move It file transfer application to upload bulk data, they should do so for the entirety of the quarter. All right, so next slide, please. So this slide outlines the reporting period and submission schedule that counties will follow. Counties will collect data on a monthly basis and submit them at least quarterly within 60 days following the close of the reporting period. So you see that on the right side of the slide. Counties can submit data monthly if preferred, or they can wait until the end of the reporting quarter. As I said, counties must adhere to this reporting and submission schedule regardless of when they begin implementing CARE. So this means that if a county begins implementing CARE in the middle of a reporting period, they will submit the data by the submission deadline immediately following that period. So for example, for Cohort 1 counties who started implementing CARE in October of 2023, their data from October through December of 2023 is due on March 1st of 2024. And for LA County, who started implementation in December of 2023, they will follow the same submission deadlines, but will only report data for the month of December. So for the rest of the counties that are coming on this year, their submission deadlines will follow this same schedule. So for counties starting CARE implementation in, say, December of 2024, they are expected to submit their December 2024 data by March 1st of 2025. And then, their January to March data will be submitted in May of 2025 and so forth. All right, so next slide. So this was a very, fast-paced, high-level overview of the data collection and reporting mechanisms. On this slide, we just wanted to provide some suggestions to prepare the counties for CARE data collection and reporting. And this is based on lessons and observations of the intensive work that has been done by Cohort 1 counties and LA County to date. We recommend, first of all, to review the statute and the data dictionary and become familiar with the data required for reporting. We really encourage you to assess where your data sources for the data points may exist within your county and begin to map data sources to reporting requirements. And then we also recommend that you understand the two options for reporting and determine which mechanism your county will use to submit data to DHCS. And then I think following the theme of collaboration that Stephanie and Charlene noted earlier, we really recommend that you begin to work with agencies outside behavioral health to develop data pipelines. And this is key to supporting reporting of many of the non-behavioral health data elements required by statute. And so as establishing those relationships early is really important. Also encourage folks to begin to develop forms and workflows to align with the care court process and the services that are being provided to ensure that you're collecting the required data by your frontline providers. And then the other piece to really note is also to consider whether or not your data team will hire a vendor to support this effort. Several Cohort 1 counties are exercising that option. And also to really work with your IT department to engineer your data systems or your EHR to support data collection as needed. And I think the huge thing is really plan ahead. You should anticipate a larger lift to prepare for data collection. And most counties will say they would recommend at least a 6-month runway to get ready for data collection and submission. All right, so Next slide, please. So on this slide, just wanted to show you what resources are available. There are live links. I won't talk through them. When the slide deck goes out, you can click through them. There's information on the data dictionary, mechanisms for reporting, as well as the file submission and QA process. So next slide. Again, another slide on FAQs and available data resources to help support data collection and reporting. So with that, I know we are running pretty close to time and wanted to make sure that we leave time for Q&A. So I am going to turn it over. Actually, there's one more slide. And this one, again, is just to show you where to submit your request for data TTA, how to reach us via the website, and to again let folks know that we are available to provide individualized TA to your county teams as requested. So with that, I am going to turn it over to Patricia.
Thanks, Serene. And we will email out some of these next steps, some recommendations of where to start and where to get going. Sam provided some of that contact information here, but we'll make sure to send this out so you can click through some recommended trainings if you're wondering, hey, where do I start? What of the trainings should I prioritize? We did want to leave some time for some of the questions that have been coming in through the Q&A and through the chat. And I have a list of questions, but please chime in. If we don't have time to discuss them, we can follow up afterwards. A few of the questions. So Stephanie, you wanted to provide the question related to Dustina's question that came through. How are counties working with probation partners on, and specifically, can folks who are on probation be referred to care? Stephanie, do you want to take that question?
Sure. What I would first say is I do think it's important to work with your probation partners. I do also want to underscore that this is a civil court process, but I also recognize, and we're kind of learning this in real-time practice, that there are people who are being referred to care who are actively on probation, of which then it's really important to have the probation department and the individuals who are working with that people in the probation department who are working with that individual be knowledgeable that this process is happening. I think more important is that this is a person who would meet the criteria for care. If the person, it depends on where they are in their journey with probation. And some people may be in their second, third year of fulfilling a probation obligation. Some people may be going through some sort of criminal diversion. This has become, I didn't want to put a response to the chat because I think this is a really finessed and nuanced area where we need to do some more thinking about pros and cons for the client, or in this case, the care participant. If the care participant has pending criminal charges and wants to participate in a diversion program that then may alleviate them from those pending criminal charges, then that might be a better decision for the care participant. And so I think these are complex things that we're working through, but I would encourage you to ensure that you are reaching out to your local probation departments, having these high-level conversations with your probation chiefs. So I hope that's helpful. It's a little nutty, but I think one of the things that we're doing with, taking cases by cases is identifying kind of these best practices. And also I think at the core, one of the principles of care is to try to provide as much self-determination as possible. And so this really also would be a decision, frankly, that the care respondent themselves should be actively participating in as much as they can. So thank you.
And thanks, Stephanie, and thanks for the question. One of the other questions that came through, how does this project coincide with CalAIM initiatives rolling out? Ivan, can you speak to this question?
Yes, and I think as most of you are probably aware, through CalAIM, we've kind of streamlined and clarified policy guidance around no wrong door, access criteria for specialty mental health services, and kind of a host of other initiatives. And these initiatives were collectively intended to ensure folks could get kind of whole person integrated care for their behavioral health disorders. And the CARE Act, for its part, is really intended to get our populations with the most severe behavioral health disorders into treatment, right? I mean, that's the ultimate goal. And so what we're hoping is that the connection between CARE and CalAIM is essentially getting folks into the kind of right course of treatment that's medically necessary and clinically appropriate. And we know that many individuals in CARE have probably either been in and out of treatment, it's been years since they've been in treatment, or perhaps they've never received treatment. And so the CARE Act is kind of going live at a time that I think dovetails perfectly with the policy updates and changes we've made through CalAIM to be able to ensure that we have kind of maximum retention of our CARE Act participants.
Thank you, Ivan. And Chris McConkey, I know we're getting close to the end, but there were a few questions that came through that we thought that that you would have a good response to about public defenders is one of the questions, and then estimated allocation. Can you speak to some of your responses there?
Yeah. So, I'm trying to remember what some of the questions were that I was typing answers to in the chat. So just let me know if I forget one. I think one question that came in that I answered was, what about counties that don't have a governmental county public defender? Like if there's no qualified nonprofit qualified legal services project that would apply, that applies to serve respondents in that county, like who performs that role? So for all I can say is that for the 23-24, that's this state fiscal year, that actually was true for one county. And what happened this year is that county's county administrative office designated an entity with whom it would contract to provide those services. And so the funds went through that office to the subcontractor that they picked. Another question that came in, and we anticipate that it would be similar with 24-25 funds unless the Budget Act specifies otherwise. For another question that came in, it was, does the governor's current January 2024 proposal, I think the question was, does it designate the allocation, the amount that would be available for public defender offices and or qualified legal services projects to serve respondents? Does it allocate it by county? I think that was the question. And the answer is, not to my knowledge, we're still reviewing the proposal, but in any case, in this current state fiscal year, the Budget Act of 2023 directed the Legal Services Trust Fund Commission and the State Bar to run a formula to identify the amount that would be available to represent respondents in each county. And the formula may not be the exact same this year because it was a formula that was taking into account the size of Cohort 1 in LA County. And but it had several features. It had like a funding floor. It looked at the proxy for need that was identified in consultation with the Department of Finance and other agencies. But in any case, the actual amount that was available in each county was subject to a formula. And that's something that the Budget Act, which typically or often passes in mid to late June, directed. So those county allocations, if the process is similar this year, would become final post the Budget Act of 24 passing. Did I miss a question that came in? Did anything else come in for me?
Thanks, Chris. There were a number of questions. I think you answered some important ones. It was mentioned in the chat, but we can circle back with some of these Q&As. We are coming close to time. Thanks for your poll responses. We saw a lot of interest in trainings and some interest in cross collaboration with other counties and other organizations. So we appreciate that. We will be sending that post-meeting evaluation. And somebody also asked for the links that we shared during today's training. We will be sharing the slides and all those links in a follow-up email. So please keep an eye out for that. And please sign up for our listserv if you haven't done that already, so you can continue to get up-to-date information. Thank you everyone for joining, and for all of our presenters. Please keep in touch. There is no wrong doors. So we shared that email address. If you don't know where to go, email that email address and we'll connect you with the right person. Thanks, and we look forward to our collaboration.